Thyroplasty.
Right, so we've established that to address the distinct morbidity of a vocal cord palsy, we need to address it, and we have a multitude of options available. My job today is to focus on medialization thyroplasty. If we compare it with the other techniques, yes, it is a separate surgery, but the skill set required is moderate at best. The effects are permanent yet reversible, and it's reasonably cost effective as well. Ever since its inception by Ishiki in the 1970s, fortunately, both the technique and the type of implants have undergone a sea change for the better. So now you have a multitude of implants to choose from. We have some knowledge from these experiments conducted by Zhang et al. That the implant does alter the body cover theory of phonation. So a patient-specific customized stiffness implant is what you're looking at that would give the best outcomes. But by and large, stiff implants are very sensitive to insertion depth. Softer implants are more forgiving. So softer implants are preferred for a unilateral cord palsy. And if you're keeping your depth of insertion anywhere between 20 to 40%, the voice is not adversely affected. In fact, it's going to lead to a better acoustic outcome. If you add a simple adjunct like an arytenoid adduction along with the medialization procedure, there have been reports saying that the intraoperative patient rating scales, you can have a VHI improvement of significant 2 to 4 points. This is an intraoperative assessment, mind you. Also, it has a very good outcome in patients who have a wide gap and a marked height difference between the two vocal folds, so especially useful for aspiration. Medialization as a procedure has stood the test of time, whether it is the voice handicap index, the maximum phonation time, or the Grabar scale that was alluded to. It has shown consistent results as a framework surgery for unilateral cord palsy. Even patients with long-term vocal fold immobility. So in this cohort, you had patients who had long-term mobility, more than 20 years the cord was palsied, and in spite of that, with medialization thyroplasty, you were able to achieve good voice outcomes. Its role in aspiration is undisputed. So if you see the study, more than 96% had decreased aspiration and 2/3 could be decannulated after performing a medialization thyroplasty. It's a safe procedure, absolutely no mortality. In the very small percentage that do require revision, success with revision surgeries is upwards of 95%. To further reduce the complications of graft rejection, we have the option of doing an autologous thyroid cartilage graft from the superior edge of the cartilage. And to reduce the complications of graft extrusion, this is an own Indian author innovation. So this is called a sandwich thyroplasty. So you have a hinged door in the thyroplastic window. The implant is placed and then the perichondrium is reposited. So this significantly reduces chances of implant extrusion, nowhere compromising in the voice outcomes. The Korean Society of Laryngology has come out with these guidelines, and they say that no one modality is superior to the other as far as voice outcomes are concerned. Only for patients who have significant morbidities, injection laryngoplasty may be chosen, and if you have already identified the injury intraoperatively, a nerve repair is chosen. An addition of arytenoid adduction is definitely recommended when there is a wide posterior gap, when there is a marked height difference in the glottis, and as a method to prevent aspiration. If you look at meta-analysis between injection and medialization, there are absolutely no differences in either the VHI or the MPT. A comparison of reinnervation versus medialization, thyroplasty was significantly able to reduce the voice handicap index from baseline to 6 months to 12 months as well. To the best of my knowledge, this is the only randomized control trial looking at reinnervation versus medialization, and age played a significant factor. So in patients who had laryngeal reinnervation but were older, that is more than 52 years, the results were not that great. Whereas in the medialization group, irrespective of the age of the patient and the age of the palsy, even in long-standing palsies, it gives an excellent outcome. So in a nutshell, a moderate surgical skill set is required, permanent reversible results, excellent salvage with revisions, and it produces reliable, reproducible, and predictable voice outcomes, especially to be preferred for long-standing immobilities, larger glottic gaps, older groups, and aspiration. Now, isn't this the exact patient set that you do want to do something for vocal cord palsies? Elderly patients with aspiration with a large posterior glottic gap. So that's probably, in my eyes, the best way forward, medialization, thyroplasty. Thank you.
I would like to call on stage Dr. K.K. Thankappan sir and Dr. Neeti ma'am for a photo, and Dr. Akshay Nayak.